Hi, my name is Tom, and this mini lecture has been designed to provide some practical advice to the pearls and pitfalls of delirium that will challenge the junior doctor. The learning objectives for this presentation have been informed by our expert panel and are intended to support junior doctors when assessing the confused and delirious patient. Common clinical issues for junior doctors include engaging in personalised care for the patient, considering safe prescribing principles, and cultivating a diagnostic curiosity. Personalised care is essential to managing delirium, and it is our role to ensure we know the patient behind the delirium so we can best manage their distress. However, knowing the person behind the patient is often lost amongst the medicalised approach to delirium. As junior doctors, we are well versed in taking a patient history and examining them. However, what can be more challenging for the junior doctor? Personalised care is essential to managing delirium, and it is our role to ensure we know the patient behind the delirium so we can best manage their distress. Knowing the person behind the patient is a skill that can be lost amongst the medicalised approach to disease states. As junior doctors, we are well versed in taking a patient history and examining them, but what can be more challenging is the skill to aptly weave their story into therapeutic interventions for better outcomes and distress reduction. Speak with the carers and obtain collateral and know who the patient is beyond the medical chart or clinical summary. Sometimes knowing simple facts about their life, like the name of their dog, what their job was, or what music brings them happiness, is enough to remove distress during delirium. Mitigating distress can reduce the risk of further escalation, concerning behaviours, and unnecessary risk of harm to self or others. Flaherty published a review evaluating the management of delirium in 2011, which clearly describes the TDAR approach. First, tolerating behaviours which we may not normally accept in the hospital environment can have better outcomes. An example of a behaviour may be a patient simply getting up from the bed space to explore the ward. Rather than escort them directly back to the bed or chair, we can allow the patient to explore and maintain some control in their confused state. Second, we should try to anticipate possible situations, discuss these at huddles or meetings, and consider how we could manage difficult behaviours to reduce stress. And third, don't unnecessarily escalate or cause agitation. For example, reorientation can often help patients in a confused state to settle into their environment. However, this is not always the case and may be seen as a challenge rather than reassurance for some patients. Consider the patient, and if they do not respond well, don't pursue an avenue that is not effective for mitigating their distress. Flexibility in an often overly structured system may be necessary for reducing patient distress and maintaining ward milieu. Ask the family how involved they can or want to be in the care of their loved one. Explain to them how they can add value and collaborate with them so they can feel included and seen. Are they able to help with safe medication administration? Do they have the capacity to soothe their parent in the evening as they go to sleep? We should be asking ourselves what is the goal for the patient, and with this in mind, we can provide flexibility to care delivery and provide a more personalised patient care approach in the management. Safe prescribing for junior doctors is an issue that affects care across many clinical pathologies and environments. We have already touched on the importance of remaining cautious when prescribing antipsychotics in this video series. However, it is an important issue that must be emphasised. As a junior doctor, we recommend always escalating to a registrar or consultant when possible, when you think there is a need for antipsychotic use. Current Australian guidelines for antipsychotic interventions apply to patients who are significantly distressed or considered to be a threat to themselves or others, and when non-pharmacological options have been exhausted without therapeutic effect. First-line therapy includes haloperidol, olanzapine, or risperidone in patients without Parkinson's disease or Lewy body dementia. If oral administration is not possible, then consider intramuscular haloperidol or olanzapine. For patients with Lewy body dementia or Parkinson's disease, quetiapine is recommended, and if oral administration is not possible, seek expert advice. The Australian Commission on Safety and Quality in Healthcare have released an antimicrobial stewardship clinical care standard in 2020. Antimicrobial stewardship is every prescribing clinician's responsibility. Antibiotic resistance is a natural feature of microbial evolution, and inappropriate use can accelerate resistance in both healthcare and community settings. Our simple message to junior doctors is that delirium does not mean there is an infection. As prescribing clinicians, we are responsible to avoid reflexive or inappropriate prescribing of antibiotics, and delirium is not an indication. All medications we prescribe have the potential to cause harm, and without a well-considered indication, you may complicate the delirium without any therapeutic benefit. Careful assessment and correlation of your clinical findings with biochemical investigations or imaging may help confirm your diagnostic suspicion. Document your findings, the reasoning for your impression, and refer to local guidelines for appropriate antibiotic use when indicated. Avoid broad-spectrum antibiotics when possible, and collect relevant urine, swabs, or blood tests prior to starting antibiotics wherever possible. Remember, don't just reach for the drugs. The absence of evidence is not evidence of absence. As a junior doctor, we recommend you maintain a diagnostic curiosity and consider your own biases when assessing and reassessing your patients. This is particularly challenging in the patient with delirium, as it is often complicated by the acute fluctuating nature of the syndrome. A negative 4AT does not mean the patient isn't experiencing an acute fluctuating delirium. However, it does suggest that at this cross-section in time, the patient performed well on that task. One single assessment should not provide false reassurance that delirium has resolved, and that is why this tool is best used sequentially over time for a specific period as clinically indicated. It is the clinician's responsibility to determine important factors such as what tools to use, what time of day to assess, and the expected duration of the longitudinal assessment. Good documentation and communication to other health staff can facilitate appropriate use of screening tools in the delirious patient. Finally, always consider differentials and mimics of delirium. This is a complicated and heterogeneous syndrome. In our video series, we presented a hyperactive delirious patient. However, patients can present from aggressive to unresponsive. Often it is the hypoactive delirious patient that can strike the greatest fear in junior doctors. Always assess your patient first. Start with the basics and consider your differentials. Remain curious, cautious, and have a comprehensive differential list when approaching the confused or delirious patient. Thank you.